So we're going to talk about anesthetic in terms of how we want you to approach your cases. Now keep in mind, whatever works in your private practice is great, and I don't want to change anything that's working. But when you come to a course, sometimes just try out a different recipe, see if it works, because maybe you find something that really changes the trajectory of how you do something as simple as anesthetic. And so we're going to talk about Citanest, Marcaine, Lidocaine 1 to 50, and Septocaine as well. So Mac, why don't you start off with like why we use the Citanest?
For the Citanest, what I've realized, any patient that's awake and Dr. Dhoon starts with the Citanest, no matter how slow or how fast he does the injection, the patient was like, wow, I didn't feel that. What did you use? And it gets them a little numb. We wait about, what would you say, maybe a minute, and then we go straight to the septo, and they don't even feel the injection at that point. It's kind of like I guess a topical, but it's an injection, and then with the septo, he just injects as quickly as he would like, and we get straight started to the procedure. So you don't have to leave the room and be like, oh, we'll be back in 10 minutes when you're numb. We just get started right after the Septocaine.
So at the end of the day, right, there's nothing special about how I do anesthetic. There's nothing special about how I do it compared to anyone else who delivers anesthetic every single day. What I have found is the Citanest first is a practice builder. And I'll go in with the 30 gauge first. Even if I like doing my blocks with the 27, I'll still drop half a carp of Citanest on this side and half a carp here. And if I'm doing all 4 quadrants, I'll go 1, 2, 3, 4. So I'm done with 2 Citanest at that point. By the time I'm done with that round, usually a minute has eclipsed or passed. And then I go to my septo and I go septo, 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 septo. So from that perspective, then by the time I'm done with my septo rounds, well, then I'm ready to get started because there's profound anesthesia that's kicked in. So the Citanest will go in and usually get the soft tissue numb. So when you administer the Septocaine or anything else, Marcaine, Lidocaine, whatever you prefer, the patients don't feel it. And there's a version where there's a lot of people who are impressed with my anesthetic technique, and I really think it's just the Citanest. It's nothing about me. The next thing that we use is a Marcaine in longer surgeries. So the Marcaine, this one has a 1 to 200,000 on your epi. So again, it's a reduced amount of epinephrine. And you can administer more Marcaine over a shorter period of time in compared to just volume compared to your Septocaine, because this is 0.5% of your bupivacaine versus your 4% of your articaine. So you can hit more of a toxicity level with your Septocaine than you can with your Marcaine. Now, at the end of the day, I like to use septo, so I only give the patient 8 septos right off the bat, and then I'm going to wait numerous hours up until I need to give them another round, and that second round could just be Marcaine. And there's a version of it, and we don't really advise you doing this unless you're really comfortable, but you can mix Marcaine with some dexamethasone and you can get prolonged anesthesia that way. We're not going to teach that at the courses, but there's just different products out there to get longer anesthetic administration for your patients, and there's products like Exparel that keeps the patients numb for 24 to 36 hours. Your workhorse is going to be your Lido 1 to 100, right? This is the workhorse. This is what everyone is really comfortable with, and it's tried and true. But I would say if you start with your Citanest and go with your Lidocaine, then at that point you're going to have prolonged anesthesia, and then you're also not going to max out on your Lido, and you're not going to max out on your epi. I like having a few of the Lido 1 to 50s ready for bleeding. If the patient is hypertensive, their blood pressure is elevated, or if they have any reason why, maybe it's like a chronic periodontal disease, you see that all that granulomatous tissue is going to bleed excessively, you can have your gauze soaked in this hemostatic agent, and just pressure with it can help. You can do injections and help with the excessive bleeding, but I don't really use this to do my traditional anesthetic. I think the amount of epinephrine in it is excessive, but if I'm trying to stop a bleed, I really. And then for me, the workhorse, I think we use this, 95% of the time?
Yeah.
Yeah, it's going to be your articaine, your Septocaine, whatever you like to call it. This you can only do a certain amount. All of them you can only do a certain amount, but this is the least amount of carpules that you can give in one dose. And just know the septo is tried and true in my hands. It doesn't mean it has to work in yours, but at the end of the day, this works really well. There's all these myths about septo causing nerve toxicity and having a higher propensity for lingual nerve anesthesias or just anesthesias or paresthesias. Quite frankly, I think the literature has been debunked on that one, so you don't have to be afraid of giving your blocks with your articaine or Septocaine anymore. feel free to do that and do that freely. It's no longer a litigious point that can be brought up against you. But from the perspective of whatever works best in your hands, that's really, if you hit your mark and you know where you are from an anatomic perspective, any of these anesthetics besides your Citanest are going to get you profound anesthesia with your cases. And then when we set up our syringes, we use 130 and 127. If the patient is completely out for the count with the anesthesiologist, I'll go ahead and just use 27s the whole way through because I can just dump anesthetic in there more quickly and I don't have to go slow. And you're less likely to have needles break and things of that nature. But if the patient is awake at all, even if they're moderately sedated, I like a 30 gauge because a 30 gauge is going to be far kinder to that patient with some Citanest, and I promise you that's going to be a practice builder.